This talk is the first talk about intraoperative monitoring of the motor nervous system. It is intended for the Nick Claus Children's Hospital Clinical Neurophysiology Fellows. This talk will be conducted in a question and answer format. The first question is, the descending motor pathway medial system innervates the trunk and proximal limb muscles. A true, B false. There are two descending motor pathway systems. The lateral descending motor pathway system that innervates the distal muscles of the limbs, and the medial descending motor pathway system that innervates the proximal limb muscles and the axial musculature. So the answer to this question is A. Next question. Which of the following tracts is not considered part of the descending motor pathway medial system? A. The anterior reticulospinal tract. B. The rubrospinal tract. C. The vestibulospinal tract. D. The tectospinal tract. I hope you remember this figure from one of our prior videos. In it, you can see a cervical spine transverse cut with motor tracts listed on your left and the sensory tracts listed on your right. The medial descending motor pathway system consists of the lateral reticulospinal tract, the anterior reticulospinal tract, the vestibulospinal tract, and the tectospinal tract. These tracts constitute the medial system. The other system is the lateral descending motor system, which consists of the lateral corticospinal tract, which is organized at the level of the cervical spine with its cervical fibers closest to the midline and the sacral fibers most peripheral. The rubrospinal tract and the anterior corticospinal tract. So the answer to this question is B. Next question. Which of these cortical areas does not contribute to the lateral corticospinal tract? A. Area 6, B. Area 4, C. Areas 3, 1, and 2, D. Area 8. Of the descending motor pathway lateral system, the most important tract is the lateral cortical spinal tract. This tract originates in the mesial and lateral cerebral hemispheres. In the lateral surface of the hemisphere, one of the area that contributes to the lateral corticospinal tract is the primary motor area, also called M1, which corresponds to Brodmann area 4. The primary motor cortex is also present in the mesial surface of the motor cortex, as you can see in this frame. The second area, also represented in the mesial surface of the hemisphere, that contributes to the lateral corticospinal tract is the supplementary motor area, also referred as SMA or M2. The supplementary motor area has been mapped to the mesial region and also to the coronal region of the same hemisphere. This area, that is a supplementary motor area, corresponds to Brodmann area 6. The third cortical area that contributes to the lateral cortical spinal tract is the premotor area. This area is also called the PMA or M3. The premotor area occupies the segment of the Brodmann area 6 that is found in the lateral surface of the hemisphere, as you can see in this frame. The fourth major contributor to the corticospinal tract is the primary somatosensory cortex, consists of Brodmann area 3, 1, and 2. The primary somatosensory cortex is present in the lateral surface of the hemisphere, and it is also present in the mesial aspect of the cerebral hemisphere. Neurons from area 4, neurons from area 6, and neurons from areas 3, 1, 2 contribute a little bit less than a third of the fibers each to form the lateral corticospinal tract. The rest of the fibers probably arise from area 24 and area 23. These fibers may influence the readiness of the anterior horn cell to be activated by other lateral corticospinal tract fibers. Brodmann area 8 contributes to saccadic eye movements and is not involved in the corticospinal tracts. So the answer to this question is D. Next question. Which of the following tests is less likely to evaluate the motor system? A. Motor evoked potentials. B. Somatosensory evoked potentials. C. EEG. D. Free running EMG. The operating room is an impressive place. This is the view from the surgeon perspective of the electrodiagnostic screen. And this is the view from the neurophysiologist's perspective. This screen is smaller than the screen that is facing the surgeon. In it, during this occasion, corresponding to a scoliosis correction procedure, we follow the left and right muscle motor evoked potentials, free running EMG, and 3 EEG channels with which we survey the motor function. In addition, in this screen, we can monitor sensory functions from the left upper extremity and right upper extremity, and from the left lower extremity and right lower extremity. These 4 panels are used for the evaluation of somatosensory evoked potentials. To complement this, we have a view of the operating field. One thing we as neurophysiologists have that neurosurgeons or surgeons in general does not have is the control window. As you can see, this window has labels and control options, which are managed by the neurophysiologist during the operation. In addition, during pedicle screw insertion, we can bring up a different panel to better visualize the motor activity. This panel is also used during monitoring of the drilling and pedicle implantation. So the answer to this question is B. Next question. Which of the following muscles is more likely to monitor the medial corticospinal system? A. Abductor Hallucis longus. B. Abductor pollicis brevis. C. Abdominal muscles. D. Abductor digiti minimi. This panel lists all the muscles being monitored by free-running EMG during a given procedure. Notice that all the tracings are flat. This is a sample of the usual normal recording at rest. In normal individuals during surgery, when the EMG tracings is running free, no potential should be seen, but at times single small amplitude, low frequency isolated discharges may occur even in normal individuals. The indications for intraoperative free-running EMG during spinal surgery is to detect motor root compromise, for the compression of a spinal stenosis and spondylosis, correction of spinal deformities and disc herniation, and during surgical procedures requiring anterior or posterior spinal cord approaches. In each of these particular procedures, depending on the particular area to be manipulated, the neurophysiologist will choose the muscles to be monitored. The choice of muscle should include muscles innervated by the medial and lateral descending motor pathway systems. The same muscles are usually monitored on the right and the left side of the body, and at times muscles from the same dermatomes on the same side are joined in the same derivation. A frequently used ensemble for correction of spinal deformation includes the left abductor pollicis brevis, which monitors the lateral system and is innervated by the medial nerve, referred to the abductor digiti minimi. This muscle is innervated by the ulnar nerve and arises from the same myotome as the abductor pollicis brevis. The same derivation is used on the right. Next, the left and right chest is monitored at T12 and at T5. The T12 and T5 recording surveys the pectoralis muscles. In addition, we also monitor T10 bilaterally, and often we place electrodes in the upper and lower abdomen. These 5 pairs of electrodes monitor the medial corticospinal system of the descending motor pathways. In the legs, we monitor the left adductor by placing the searching electrode in the belly of the abductor's muscles and the reference electrode in its tendon. We also monitor the left quad, referred to its tendon, the anterior tibialis muscle, referred to its tendon, the hamstring muscles in a similar fashion using the belly to tendon arrangement, and we use the same technique to monitor the left gastrocnemius, referring it to its own tendon. The last muscle we analyze or monitor on the left side is the left abductor hallucis longus. The same muscles that we monitor on the left, we monitor on the right in the same fashion. So the answer to this question is C. Next question. Which of the following muscles is most often used to study C7 anterior root? A. Biceps. B. Flexor carpi radialis. C. Abductor pollicis brevis. D. Abductor dieti minimi. Knowing the segmental innervation and the path that fibers take to innervate a muscle is of paramount importance when performing intraoperative monitoring. In the cervical area, the C2, C3, and C4 segments innervate the trapezius and the spinal segment of the sternocleidomastoid muscle. The C5 and C6 segment innervates the deltoid and the biceps. The C6 segment innervates the tricep and the extensor carpi radialis. The C7, the flexor carpi radialis. The abductor pollicis brevis and the abductor dieti minimi are innervated by fibers from C8 and T1. Muscles innervated by the same segment make good pairs to join in a derivation to detect root compromise of the specific roots. In the thorax spine, we can study the upper rectus abdominis innervated by fibers from T5 and T6. In the middle rectus abdominis innervated by fibers from T7 and T8. In addition, we can monitor the lower rectus abdominis innervated by T9 to T11 and the inferior rectus abdominis innervated by T12. At the lumbar segment, we can monitor the vastus medialis and adductor magnus for roots L2, L3, and L4, the vastus lateralis and the tibialis anterior for root L4, L5, and S1, the peroneus longus and the gastrocnemius for L5 and S1 roots. The sacral region is evaluated by monitoring the gastrocnemius for roots S1 and S2 and the external anal sphincter for roots S2 to S4. In this frame, I have copied the chart from which I gathered the information that I just gave you. Now I am introducing a different source which, as you can see, suggests different muscles to be evaluated for a given root. As you can see, there is agreement regarding some muscles, root combinations, but not for others. For example, in the initial table, you can see that the flexor carpi ulnaris is chosen as the muscle to study in case of needing to monitor the C7 root. Whereas in the other table, the suggested muscle to study the C7 root is the triceps or the extensor digitorum communis. So the answer to this question is B. Next question. The same panel used for monitoring free-running EMG activity is used to evaluate electrically stimulated EMG activity. A. True. B. False. During most of the surgery, the normal patient will show no EMG potentials in the free-running EMG panel. But it is important to remember that if a nerve is quickly cut, either a brief potential is followed by the muscle being quiet, or the muscle will remain quiet from the beginning. If the nerve is mechanically disturbed, electrotonic potentials will arise. When a root is electrically stimulated, we will see EMG activity. I have used the term in this talk complex muscle multifocal waveform or multi-spike waveform instead of the term compound muscle action potential to refer to this finding. So the answer to this question is true. Next question. Please take a look at this frame and determine which of these structures is the pedicle. A1, B2, C3, D4. In this frame, you can see a transverse and lateral view of a vertebral with the corresponding numbering. Number 1 is a lamina. Number 2 is a spinous process. Number 3 is a pedicle, which I have now highlighted in the lateral view. And number 4 is the transverse process. So the answer to this question is C. Next question. Pedicle screw placement should go through the intervertebral foramina. A true, B false. Take a few seconds to look at this frame. Notice the relation between the intervertebral foramina and the pedicles. Were we to cut at the level of the green line, we would see a transverse cut of the vertebra going through the intervertebral foramina, where we would see the dorsal root, the dorsal root ganglion, the ventral root, and the spinal nerve. But if instead of cutting at this level, we were to cut at this higher level, we would not see in this new transverse cut the content of the intervertebral foramina. We would see the pedicle, which is the right location to place the screw. This is a lateral view demonstrating the correct position of the screw in relation to the intervertebral foramina. So the answer to this question is false. Next question. Motor evoked potential recordings using transcranial electrical stimulation is not contraindicated in patients with A. Epilepsy, B. Skull defects, C. Increased intracranial pressure, D. Myasthenia gravis. During surgery for spinal rod placement, motor evoked potentials are usually monitored, but there are certain contraindications. These contraindications are epilepsy, cortical cerebral lesions, skull defects, increased intracranial pressure, surgically implanted intracranial devices, or cardiac pacemakers or other implanted pumps. It is also important that when patients are undergoing this procedure, that this patient have bite blocks to protect their tongue and teeth. So the answer to this question is D. Next question. Motor evoked potentials are less sensitive to sedation than somatosensory evoked potentials. A true, B false. The results of motor evoked potentials and somatosensory evoked potential here shown were recorded in rodents, but apparently the same applies to humans. As you can see, as the concentration of nitrous oxide goes up, the cortical and cervical triggered motor evoked potential's amplitude goes down. And then, after taking off, that is after stopping the nitrous oxide, those potentials start increasing again until they are back to normal in this experiment about 10 minutes after the nitrous oxide was stopped. Notice that this pattern is present with cortical stimulation and with cervical stimulation. That is, MEPs, regardless of being cortical or cervical, are significantly sensitive to sedation. Now notice that during somatosensory evoked potentials, hardly any changes occur in comparison as to those that occurred during motor evoked potentials in the same situation. So the answer to this question is false. Next question. Please take a look at this frame. Judge what the implication of the EEG findings are and choose. A. Give Valium. B. Give short-acting phenobarb. C. Apply cold saline to the cortex. D. None of the above. This frame shows the computer screen while monitoring multiple parameters. As you can see, cortical activity is one of those parameters being monitored. The stimulus used to trigger motor evoked potentials transcranially is at times linked to seizure activity. That since patients are usually paralyzed, these seizures are not detected clinically and are only detected by EEG epileptic changes as the one you see in this frame. In this case, the seizure started on 10:42:40 and stopped at around 10:42:50. Seizures triggered by stimulation are usually short, lasting less than 10 seconds once the stimulus is withdrawn. Most authors believe that the best approach is to get ready to treat the seizures, but only to initiate treatment if the electrical seizure goes on for 10 seconds or longer. Episodes lasting more than 10 seconds require action, which range from giving Valium, using short-acting barbiturate, or applying saline to the cortex. So the answer to this question is D. Next question. Motor evoked potentials triggered by magnetic stimulation are different than those triggered by electrical stimulation. A true, B false. Motor evoked potentials can be triggered by transcranial magnetic or electric stimulations. In this frame, you can see a representation of a pyramidal cell with its apical dendrite, which can be divided into a distal portion and a proximal portion, the neuron body, and the axon hill or initial segment. I have now represented a resting membrane potential, emphasizing the distribution of charges, which I have represented at minus 70 millivolts at the dendrite and at the axon. At this junction, the voltage-gated sodium channels are closed. Hyperpolarization of the dendrites, during which it will reach, let's say, a negative of 99, that is minus 99, would produce a current with depolarizing effects in the axon, which it will be brought, in this example, the initial segment to minus 40. This decreasing negativity at the level of the axon hill will trigger the opening of the voltage-gated sodium channels, leading to an action potential that will travel through the axon. This action potential is labeled a motor evoked potential because it refers to the excitation of the upper motor neuron. Ultimately, the potential reaches and excites the anterior horn motor neuron, which triggers an action potential that will excite the muscle. Now I have come back to the frame that we used to start answering this question, when I told you that motor evoked potentials can be triggered by transcranial magnetic or electric stimulations. I have done so to tell you a few words about magnetic stimulation. Magnetic stimulation is accomplished by conversion of electricity into magnetism, which then generates a current in the brain that excites the upper motor neuron. I do not understand the nitty-gritty of how this happened, but I will tell you what I think I know. An electrical circuit having a power source, a capacitor, and a coil wire, which are usually referred to as magnetic coil, constitute the basic electronic components needed to generate the magnetic force. After charging the capacitor in the S1 circuit, this circuit is open. Then the second circuit, which was pointing up because it was open, is closed. When this second circuit is closed, current gets going in one direction and then returns in a different direction, looping around the magnetic coil. This current is called the inducing current. The inducing current leads to the creation of a magnetic field, which then produces another electrical current in the opposite direction as the one that produced the magnetic field to begin with. Then this current produces an electric field, and it is this electric field that activates the brain cells. Specifically, it activates the pyramidal cells, which I have here represented in the resting state as I have done just a few seconds before. These neurons in this state, influenced by the effect of the magnetic field, will be hyperpolarized at the level of the dendrite. This hyperpolarization at the level of the dendrite will lead to the polarization of the axon heel lock. The depolarization of the axon heel lock will open the voltage-gated solving channels and the production of a motor evoked potential, which upon activation of the lower motor neurons will produce a muscle contraction. This muscle contraction is termed muscle motor evoked potential. In addition to transcranial magnetic stimulation, motor evoked potential can be triggered, and usually they are showing the OR, by electricity. This is a representation of the discharging device. Recall that the anode or positive pole of the discharging device may be represented by an open circle, and the cathode, the negative pole, by a solid circuit. The anode can also be represented by a white and a red circle. The cathode can be represented by a black circle. In all this frame, since the background is black, I will use gray to represent the cathode and white or red to represent the anode. So, if going back to the pyramidal cell at rest, this cell is exposed to a discharging electrical device which is turned on. Positive charges from the anode will discharge. In this frame, I have placed the tip of the discharging device on the scalp and added the positive charges discharged from the anode. As you can see, they're going to be surrounding the distal portion of the apical dendrite. These charges will produce an attraction of intracellular negative charges to the distal portion of the apical dendrite. The movement of these intracellular charges will hyperpolarize the axon and cause a depolarization at the axon heel lock initial segment. This will lead to opening of the voltage-gated solving channels and the production of a motor evoked potential, which is just an action potential triggered in an upper motor neuron. So the answer to this question is B. Next question. During a spinal stimulation, the initial depolarization occurs under the anode. A true, B false. With cortical stimulation, depolarization occurs under the anode. With a spinal stimulation, depolarization occurs under the cathode. I hope that you remember this figure from a prior video. The reason for the depolarization to occur under the cathode in the spine is that in the spine the elements being initially depolarized are axons. So in the spine, as well as in the nerve, depolarization will occur under the cathode. So the answer to this question is B. Next question. Which of the following is not the consequence of a motor evoked potential? A. D wave, B. F wave, C. Nerve motor evoked potentials, D. Muscle motor evoked potentials. Magnetic or electric stimulation of the brain, the spine, or a motor or mixed nerve will produce a motor evoked potential. Yet, when this motor evoked potential is triggered at the level of the nerve, the term we use is motor nerve conduction to describe the progression of the action potential along the nerve and the muscle reaction that we label as compound motor action potential. When the whole muscle is being surveyed by a superficial electrode, or if the muscle is being surveyed by an internal probe only capturing a limited number of fibers, we use the term complex multi-spike motor potential. Nevertheless, during this talk, I will mention and use motor evoked potentials to include potentials resulting from stimulation at the level of the brain, the spine, and the nerves. So, when the end result of a motor evoked potential is recorded at the muscle, we will talk about MEPs. This is an example of an MEP, which can be triggered not only by electricity but also by magnetism. When a motor evoked potential is recorded in the spine, the potential is labeled D for direct and I for indirect, that is D wave and I waves. So the D and I waves can be triggered by another electrical stimulation of the brain or cathodal stimulation of the spine proximal to the recording electrodes. The recording electrodes have to be on the spine or on the epineurum and refer to an electrode in a relatively quiet place in the surgical field in order for us to be able to capture D and I waves. D waves can also be triggered by magnetic stimulation at the same sites as electrical stimulation, but magnetic stimulation does not produce I waves. So, as presented in this frame, you can see that motor evoked potential can be recorded in the muscle, in the spine in the form of direct and indirect waves, and they can also be recorded at the level of the nerve. For example, at the level of the brachial plexus. Motor evoked potentials recorded from the nerve are called N motor evoked potentials. And they can be triggered by a nodal stimulation in the cortex or cathodal stimulation in the spine or in a nerve proximal to the recording site. As we previously mentioned, when the stimulus is at the nerve, the more often used term for a nerve motor evoked potential is simply a nerve conduction study and a compound muscle action potential. The same can be said about magnetism in regard to producing a nerve motor evoked potential. If you recall, one of the possible answers for the question we are addressing is F wave. This wave will be addressed in a second part of this year when we talk about peripheral nervous system and EMG. But for now, I will just mention a few facts. In order to understand F waves, we need to understand M waves and also H waves. When studying nerve conductions recording from a muscle with the typical electrode black to black arrangement, which I have further simplified in the lower part of this frame to show it in a more schematic fashion, you can see the different elements involved. Were we to apply a current of, let's say, 10 milliamps with a black to black electrode position, the relevant current will travel distally, and as a consequence of the polarization of the motor plate and the motor fibers, a response will appear that we call the M wave. At this point, For understanding the M wave, we will disregard the proximally moving current in the axon. We also have another wave that we have to understand before we understand the F wave, which is the H wave. The H wave in neonates can be obtained from all muscles, but by the age of 2 years, it can also be obtained from the soleus or the flexor carpi ulnaris. So let's consider that the arm in this figure belongs to an infant. In order to trigger the H wave, the stimulator is turned so that the cathode faces proximately, and the stimulus, in order to be effective, needs to be low intensity and of long duration. This way, the 1A fibers will be preferentially stimulated and the motor fibers will not, hence avoiding an M wave. So once these fibers get activated, the electrical volley will travel proximally and make contact with the anterior horn motor neuron, as represented by the thin blue line in the magenta dorsal neuron. And in the spinal cord, the motor neuron becomes activated and the electrical volley travels back to the muscle to produce an H wave. It is the back and forward trajectory that confers the title of H reflex to this electrical phenomenon. Now I will talk about the F wave. If we increase the stimulus to, let's say, 20 milliamps, 1A fibers, but also motor fibers will be activated. The distally moving electrical volley will go on to produce an M wave, whereas the proximal traveling electrical volley will travel through the motor axon back to the motor neuron and activate some of the motor neurons. Some of these activated motor neurons will become excited and will produce a traveling electrical volley that will produce the F wave. In the next frames, I will show how it looks. In this frame, you can see a column. The width of the column indicates the intensity of the stimulus. High up, the stimulus is little, and low down, it is strong. When low intensity stimuli are applied, we see a late wave, let's say 22 milliseconds after the stimulus. Then, after a few stimuli, in this case 2, as the intensity increases, you start to see two waves, the late one and an earlier one that will be smaller than the late one. With subsequent progressively increasing stimuli, the amplitude relation will switch and the earlier response will get bigger and the late response more and more smaller till it disappears. And then a further increase in the intensity of the stimuli will produce a bunch of little waves at about the same time as the initially elicited late response had occurred. You know that the early response is called the M wave. The initial elicited late response is called the H wave or reflex. And the last triggered and late occurring wave is the F wave. I have added the new figure to stress the time relation between these responses. As you can see, the H wave or reflex and the F wave coincide in time. And in the new graph at the bottom, you can see the correlation between amplitude and stimulus intensity. Each wave starts with least stimulus and achieves a certain amplitude and then decays. The M wave starts later when the stimulus is a little bit stronger and it increases in amplitude. At the highest amplitude of the M response, as the stimulus continues to increase, the F wave appears. The F wave never reaches the amplitude of the H wave. So the answer to this question is B. Next question. Transcranial muscle motor evoked potentials can be used to A. Map the origin of the pyramid tracts. B. Determine central motor conduction. C. Diagnose multiple sclerosis. D. Monitor the spinal cord during surgery. Transcranial motor evoked potentials can be used to map the origin of the pyramidal tracts. This can be achieved by tracking the amplitude of the muscle motor evoked potentials. Yet, in order to achieve this task, we need to use a figure-of-8 stimulator because it adds precision to the magnetic field, thus allowing relative pinpoint precision. Then, using specific points of stimulation and activating those areas, we will come out with muscle motor evoked potentials of different amplitudes. The highest potential is likely to indicate the location of the origin of the pyramidal tract. Smaller potentials indicate the surrounding area. Central conduction time can also be achieved by the same method. This frame portrays a right-hand muscle motor evoked potential triggered by a nerve stimulation. This can be done in the right, and also it can be done on the left side. In this frame, you can see the results of this stimuli and recording. From the right, abductor DAT minimi, and from the left, abductor DAT minimi. Next, the stimulus is applied in the spine, that is in the cervical spine, and its effects are recorded on the right and left hand simultaneously. In this case, the site of the stimulation was C7 to T1. Next, the stimulus is applied in the right hemisphere while recording from the left hand, and in the left hemisphere while recording from the right hand. In this frame, you can see the results from scalp recordings pointed by the arrow. So the calculation for central conduction, that is the difference between what it took for the scalp stimulation to produce a muscle potential and what it took for the cervical stimulation to produce a muscle potential, can be calculated. In this case, the result is 5.5 milliseconds. The determination of central motor conduction can be used, but it is not diagnostic of multiple sclerosis. I have just introduced the wrist-generated potential in case of a multiple sclerosis patient that had normal strength. Now I have introduced the cervical generated potential, and now the scalp generated potential. The central conduction in this case was 16.5 milliseconds from the left hemisphere to the spine and 14.1 milliseconds from the right hemisphere to the spine. These constitute a significant abnormality in regard to being prolonged on the patient affected with multiple sclerosis, but also on the fact that it is very asymmetrical. Motor evoked potentials have also been used in psychiatry for the diagnosis of psychogenic paralysis. Some authors have concluded that in the appropriate diagnostic content, a normal motor evoked potential implies a psychogenic cause of paralysis. Yet, we must be aware that transcranial motor evoked potential recorded from muscles is subject to change depending on the content of consciousness. When a person thinks about things not related to the test, the amplitude of the wave is much smaller than when a person concentrates their thoughts in the hand being tested. And this, as you can see, is a consistent finding achieved by some individuals. So the answer to this question is C. Thank you very much for your attention.